Thanks for the kind introduction. I hope that you can hear me. And first of all, let me say thanks a lot for the privilege to be able to open or kick off this day today with the topic of mental health. I think this is far from given, and I also feel the obligation to make something out of it here. So how can we actually use novel digital technologies and AI to transform the field of mental health research? And to start with all of that, let me take you back to where it all began. Many of you will probably associate this person here, Sigmund Freud, with mental health. And of course, what the godfather of psychotherapy did 100 years ago, roughly 100 years ago, was all focused on talking to the patient. Conversation with the patient was key for diagnostic and also for treatment. And while this approach has led to the development of very fine-grained psychotherapeutic approaches that we still use today, we still face major challenges. First and foremost, we still cannot predict who will benefit from which therapy, which is a major problem in mental health treatment, as you can imagine. Luckily, the field of mental health research has changed a lot within the last decades. Nowadays, of course, talking to the patient is very important still, but we do have a range of other data modalities that we are using in our studies on mental health research. We can use different types of biosamples, biomaterials. Of course, we have neuroimaging available as a very important tool to understand the mechanisms behind mental health symptoms. And I think Ilona Croy will also go into this in more detail later this day. And I think very important, we do have digital phenotyping tools at hand. So methods of acquiring time series data, Markus Reichstein touched about this, to understand a more detailed about the dynamics behind mental health problems. And I will touch about these 2 points here in detail, and I will try to explain in the next slide why I think that these two are of particular importance. Digital phenotyping tools, for us, this basically means using mobile devices such as smartphones to acquire information about symptom changes, symptom dynamics, and also the behavior of our patients at very high temporal resolution and also with high ecological validity, meaning that we can be informed about the symptom change and also the behavior in our patients in their real life environments. And this is something that we just didn't have decades ago. And what this actually enables us is to gain a very detailed understanding about how symptoms are changing in our patients. And what we see when we do these kind of studies is that there is a big heterogeneity between patients and between the treatment course and the disease course in our patients. To give you one example, many of you will probably know that childhood maltreatment is a very important risk factor for the development of mental disorders. And what we have been able to show, we and others with these approaches, is that actually, for example, depressed patients who have been suffering from childhood maltreatment show a very distinct disease course and symptom development with lower remission rates, more residual symptoms, and higher relapse rates. Very important information if we think about custom tailoring interventions in the future. Second, how can we use neuroimaging? I briefly touched on this. Neuroimaging, of course, is a very mighty tool for us to gain insights into the mechanisms behind this relationship. And for the case of childhood maltreatment, we and others have been able to decipher within the last years that actually there are specific changes in the brain on a structural and functional level that actually mediate the relationship between a risk factor such as childhood maltreatment and, for example, the risk to relapse in depressive episodes. The question now, of course, is how can we use all this information, all the fancy data, to actually advance our field, to also advance clinical routine? And within the last couple of years, machine learning techniques, pattern recognition techniques have been in the center of our interest. What does this mean for us? We have been trying to train machine learning classifiers on data first and foremost from our studies that we have been performing. And what we have been doing, this is just one example, is that we take these study cores that we have at hand and we try to train machine learning classifiers on the multitude of data that we acquire to then come up with predictions of clinically relevant endpoints such as depression relapse. This is just one example showing you that here we learned that actually multi-model classifiers outperform classifiers that are trained on one data entity, probably not very surprising. And of course, this has been a big hype in our field, but within the next 1 or 2 minutes, I want to touch more on the limitations of this approach. I was talking to you about the fact that this is all based on study cohorts. So what we and others have been doing within the last couple of years is the following. Please imagine, this is our hospital actually, just a couple of 100 meters up the hill, and just imagine that this is the entity of patients presenting at our hospital each day. What we and others have been doing in the last couple of years is basically to select a rather small subset of these patients based on pretty strict inclusion criteria, to include them in our studies and then to characterize them using very fancy methods such as imaging and genomics. The problem is that, first of all, this rather small subpopulation probably does not reflect the real-world heterogeneity of our patients. That might differ a lot from our study populations. And second of all, we actually do not have the entity of these data sources in all of our patients that we are treating. So the problem is that probably we won't be able to actually use classifiers trained on these data in the entire population, but we should move away and think about approaches that rather look like something like this. We actually have to use data that reflect clinical heterogeneity. So basically we need the opportunity to train our machine learning models on data that reflect the entity of our populations that we treat each day. And with the remaining time, I want to show you 3 examples of how we, especially in the German Center for Mental Health, are thinking about how we can transform this and how we might actually achieve this for mental health research. First of all, I want to touch a bit more on the possibilities of digital phenotyping or remote monitoring systems. We heard about this a bit. I went on about this in the first slide of my presentation. But just bear with me for a couple of minutes. What are we doing here? Of course, I already mentioned that one possibility is just to ask the patient questions about his well-being, about his symptoms at a very high frequency, for example, using smartphone devices. We and others have been doing this extensively. Even more interesting, I think, we have the opportunity to acquire completely novel sources of data that we haven't been dreaming about within the last couple of years. For example, of course, we can use the GPS data, the information about the location, where has the patient actually been. And if we combine this with further data sources, we can infer, for example, has the patient spent more time at home than usual? Has the patient spent more time at social places or in shops and so on? We have been hearing a lot about climate. Actually, the big Congress of Psychiatrists next year in Berlin will be a lot about climate change and its influence of mental health. Using these approaches, of course, enables us to associate this and to see how regional changes in climate might interfere with mental health. Another very interesting approach to my mind, and I think this also has a very strong foundation in Jena, is to use voice samples. What does the voice tell us about mental health? We know that there's probably a very strong connection here, and of course, using smartphones, what we can do is to acquire voice samples in real-world scenarios or situations of our patients. And we can use approaches such as natural language processing to transcribe and to gain insights into how content of speech changes, but also about how the physical properties of the voice changes. Just one very brief example. People who are depressed will speak slower. Their speech will change with regard to content. If people have something like a manic episode, speech or language will speed up and will change. They will talk about grandiose things. And of course, this is still in its very first steps, but we can still see that just using the content of the voice samples enables us to differentiate between depressive and non-depressive states. Last example here, this is one example where we're working together with Joachim Denzler. This is a BMBF-funded project where we are trying to acquire physiological data from smartwatches that many of you will wear today to use the ECG signal to differentiate between periods where people will experience stress during their daily life and periods where they are non-stressed, with the vision to maybe also detect and predict in the future situations which are stressful and maybe harmful for participants. So I hope that I could convince you that these are very exciting tools of high relevance for mental health research. The question now in the second step is, how can we actually use these approaches to advance our knowledge base? And one very, very important priority of us within the German Center of Mental Health will be to roll out these technologies in representative, large-scale digital cohorts. And in the next 2 minutes, I want to show you what this actually means. Within the German Center for Mental Health, we are now building up an infrastructure called Federative Cohort Management, which we are leading out of Jena and Halle. What we are doing is basically to build up large, purely digital cohorts, where, as you can see here, collectives of several thousand patients will be asked to continuously provide us information about their mental health status based on mobile digital assessments. We already have one very big cohort, the DigiHero cohort, originally initiated in our partner site Halle, where we have included roughly 100,000 participants so far, with approximately 8,000 participants in Thuringia. So I can confirm that Thuringia actually, population here is open towards these kind of solutions. And as you can see here, the DigiHero cohort is basically centered in Middle and Eastern Germany. We will complement this within the DZBG with a second very large cohort of 100,000 participants from Bochum who will cover Western Germany. And what this actually means is that we will have the tools in hand. We will have a tool to continuously monitor mental health in Germany in very large representative cohorts. The nice thing about this approach is its flexibility. We can respond and adapt, of course, our assessments with regard to what is happening in our environment, in our world. And I will show you one example of how we have been doing this in the past. As you will all know, in February 22, Russia invaded Ukraine. And what we did in the DigiHero study was that just a few days after this invasion, we came up and designed a new assessment that we pushed out to our collective, and within just a few days, roughly 20,000 participants provided information about how they perceived this invasion, what the invasion actually did with their feelings of fear, what they were expecting that might result out of it. And I think this is really a very interesting example to show you that, of course, this provides us information about things that are happening in our real life can be tracked. The consequences for mental health can be tracked approximately in real time, and we can put it, of course, into context. If you have this kind of continuous monitoring approach, you can see how big is the influence of such an event in comparison, for example, to the pandemic or to other ongoing things that are stressing us. And as you can see here, the impact of the war in Ukraine, of course, was very, very strong when it happened. And, of course, we can try to identify vulnerable populations by differentiating who is actually experiencing more fear than other populations. As you can hear, for example, we continuously very strong differences between males and females, which is also reflected in the rates of psychiatric disorders. Within the last couple of minutes, I want to try to tell you that ultimately what we're aiming at, of course, is actually to go one step further. And the next step for us as clinicians, for me as a psychiatrist, would be to say, it's very nice to have these representative cohorts, but ultimately what we want to do is we want to use these approaches in day-to-day clinical practice. And to do this, we have to transform the environment in our hospitals and our clinical routine procedures. Of course, this is a very vast field. Just to give you one example, we are now trying to also transform this with regard to digital assessments in our processes in the hospital. What we have been doing in the last couple of years is to introduce digital assessments via mobile devices by asking clinicians and also the patients regularly about the treatment status, their symptoms, and so on. What we can then do is, of course, to annotate this information and to present them to clinicians, for example, in the electronic health record. One very important aspect that we want to touch about here is that, of course, it all depends on designing these solutions in a way that make it easy for the patient and also the clinicians to use them, because acceptance is key here. What we've been seeing in our pilot study is actually that this was quite promising, because we didn't do a lot about coaching or training the staff, and you could see that in our pilot year of the study, approximately 70% of our patients voluntarily gave these kind of digital assessments to us, 70% of the clinical staff. That means all, not only doctors, nurses, physiotherapists, were using these novel data sources, which I think is promising. And lastly, of course, this enables us first, for the first time, to systematically compare how actually our clinical routine data might differ from study data. I said that we suspect that there might be systematic differences, and for the first time by doing so, we were able to systematically investigate this and basically to see our hypothesis confirmed. our clinical routine samples differ from our study samples with regard to psychiatric history, to medication, and so on. This is probably too complex for now. I just want to tell you we have to use this information to adjust our machine learning models. And of course, what we will be working on within the next couple of days, this is just one example, is that we have to try to validate our models on clinical routine samples. This is what we have been starting on. This is data from the last weekend or so, where we've been trying to train and to bridge a classifier that we've been training on the study cohort and to validate it in clinical routine to find the features that are actually predictive in day-to-day clinical routine samples. What will be key within the next couple of years, I think, is to bring together different partners in Germany. I think it's very exciting times. We are very happy to have the German Center here in Jena, but we have to work strongly together with the established partners in the field. And for us, I think, basically the medical informatics initiatives will be very important. We have established a strong connection with them in the German Center for Mental Health. And of course, the Netzwerk Universitätsmedizin, also in the field of medicine, will be very important for us. Here, of course, the Raccoon network that some of you will know has established very interesting and mighty structures in Germany to conduct federated and central machine learning on clinical routine data. With this, I'm at the end. I just want to say again that we still have a long road ahead of us. I think, or I try to tell you that there are big challenges, but also very interesting opportunities that, and I'm convinced of that, will fundamentally change mental health within the next 10 years or so. And this is what actually motivated me to go into mental health and also motivated me to come to Jena, because I think it's a very stimulating environment. We have very strong partners here with regard to AI and informatics, and I'm really looking forward to the next couple of years here. And I hope that being in Jena in the next couple of years, we will actually end up here being able to use AI methods in clinical routine to try to do nested precision RCTs and to see if AI really helps us to achieve custom-tailored therapies in psychiatry. And with this, I want to thank you again for the opportunity. Thanks to my team and my partners here, especially André Scherak. Thank you for the attention.